It's my pleasure today to be here to interview Joe Broderick about some very exciting data that he's going to be presenting at the meeting today. My name is Argye Hillis. I'm the editor-in-chief of Stroke, and Joe doesn't really need any introduction, but he's going to tell us about a trial that has finished and has led to another trial. You want to just recap the important results for us?
Sure, Archie. So FASTEST is a global trial. It's funded by the NINDS and also funded by the Japanese funding agency, AMED. And the goal was to find a treatment, a hemostatic treatment for patients who have spontaneous intracerebral hemorrhage, and to do so within 2 hours of onset, which is very, very fast. To do that, we had to do a couple things. One is we used what's something called exception from informed consent in the United States, which allows you to enroll people even if you haven't gotten the written consent, if you can't find somebody initially. And we use emergency consent procedures in other countries, except for Japan, interestingly, who doesn't have emergency consent, one of the few countries that doesn't. So we set that up. We were going to treat within 2 hours. We chose people who had not enormous hemorrhages, but less than 60 milliliters and more than equal to 2. And then it also didn't have large areas of blood in the ventricles. And we started and we enrolled 626 people in the study. And at our second interim analysis, the DSMB, who was looking at 424 persons that had been enrolled and followed 6 months, said, hey, look, we recommend that you stop right now overall for futility overall, but we also want you to think strongly about reconfiguring the study and only entering patients who have a spot sign on a CT angiogram. And just to orient, a spot sign is when you do a CT angiogram, you're putting contrast dye in, and that dye can leak into the bed of the hemorrhage. It's like a marker that you still got bleeding going on. And so that's the group that we'll talk about in terms of the results. But what we found is that it didn't improve outcome overall in terms of our primary outcome, which was on the modified Rankin score, which is a measure of disability. 0 to 2, which is functionally independent. 3 means you can walk some, but you're not independent. And 4 to 6 are really more serious levels of disability and death. And on that primary outcome, there was not a difference overall. There was not a difference in the per protocol. And there was not a difference in the group that was 70 years or younger, which is one of our particular interest group. When we looked at our major secondary aim, though, the drug actually decreased the growth of hemorrhage. So it did by about 3 3/4 cc's or milliliters, which is about half a teaspoon in those people that got factor VIIa versus placebo. And for the intracerebral hemorrhage plus intraventricular hemorrhage, it was about 5.5 milliliters that was different. But that didn't equate to improvement in clinically. We also found that, again, not surprising, which we expected, about a 3% increased risk of thromboembolic complications in patients who got the factor VIIa versus placebo. No other secondary endpoints of safety were different. What was really the interesting part of the study starts, though, when we look at our predefined subgroups. And the 2 subgroups which had strong signals of efficacy were those that were treated within 90 minutes, so the most rapidly treated, and those that had a spot sign on the CT angiogram. The odds ratio were 1.82, 1.84. Those crossed 1, so at 180 days, it wasn't quite significant, but at 90 days, the odds ratios were 2.7 and 2.5, so it was very highly significant. So we had this clear clinical signal, but what's important is when we look at what the clinical signal is linked to, that really is what tells the story. Because when we looked at the volume of growth, most of the growth that we were preventing were in the patients who had a spot sign or were treated within 90 minutes. So for example, if we look at ICH plus intraventricular hemorrhage, the amount of growth that was decreased in the patients without a spot sign is about half a teaspoon, about 2.5 cc's. When you look at the group that had a spot sign, it was 14 cc's or 14 milliliters, which is about a tablespoon. So you had this big change in the growth of hemorrhage in the spot sign group. And when we look at the less than 90-minute treated group, we had about twice the volume of decrease in growth compared to those people that got treated later on. So we have this clear linkage of really stopping growth in these people who had the most risk of bleeding, and then that corresponds to clinical benefit. Now, we need then to test that in the second trial, which is the FASTEST Part 2, which we're focusing on those two subgroups alone, and we will see what we see.
See, the trial really proved that it is successfully hemostatic, that it stops bleeding, but you have to stop it while it's still going on.
Right. If you give a drug that stops bleeding to somebody in which the bleeding is almost all stopped, you don't help them at all, and you just increase the risk. So you have to identify those which have the highest risk. And one of the other things we learned from the trial is that we weren't sure how much blood you actually had to stop bleeding to get a clinical effect. We thought it could be, we said at least 3 to 4 cc's, but it's probably more than 6 or sometimes even more than 12.5 cc's to really have that impactful outcome on clinical function.
Yeah, well, that makes sense. It's very exciting. It seems almost like the time when we were first approving TPA. You know, can we really get to these people fast enough to do some good? Can you tell me about the role of the mobile stroke units? I saw quite a few of the centers had mobile stroke units.
Right.
And was that necessary?
So the mobile stroke units treated people about 20 minutes more quickly than if they got it in the emergency department. The centers that had a mobile stroke unit generally treated more quickly than centers that didn't. The number of people on the mobile stroke unit actually treated was smaller than we expected, but part of it is that they were getting evaluated in the mobile unit, and by the time they had gotten them ready to be treated, they were at the emergency department. And so they got the rest of their medication there. But it clearly made a difference, and we'll have some more data about that coming out in the upcoming months and when we talk about that role, and probably at the European Stroke meeting coming up here. So, but it's important. We're learning still a lot about the trial. We have a lot of interesting data that'll be coming out over the next year. But I think your comment about its role with TPA, for me, resonates because I was involved with the original pilot trial back in '87, and it's still about time.
Yeah.
Physiologic time, which is the kind of the measurement of who's still bleeding, but time is so important. And we have to live with the biology that we're given, right? You know, biology is a harsh mistress in some respects. We have to fit within the biology we're given. But if you remember the TPA story, the original patients that we treated after the trial, we treated about 1% of all ischemic stroke patients. It wasn't for about another 10 years until we changed how we process things, the imaging data that we got, that it now expanded up to, in Norway, they recently reported 21%. So if you can get a foothold and you show it works, then you can expand out to other populations that still may benefit, but time is still going to be important, and no matter what part of the world you're in.
And I do think some of the public health information and projects to educate people about the importance of time have been very successful. So, you know, we used to really only treat, even here, 5%, and we're really doing better, I think, at getting people in more quickly, but we've got some room to go. Tell me if you think the MRS is the best measure of outcome in these patients. I know in some clinical trials, people are concerned about the MRS because it doesn't pick up mild deficits, but these people have major disabling deficits. So is this a good outcome?
I think the MRS is a pretty good, you're not worried about the floor here, you're worrying about the ceiling because these are really sick patients, you know, and so I think the MRS works pretty well. There's other scales that are helpful and tell you more information as well so we don't just do the MRS, we use things like the quality of life index, EuroQoL. We use other measures as well, but the point is it's been a tried and true kind of measure. We kind of understand it pretty well, and we can translate it into what it means for patients, which is a nice thing. And
do you think the thromboembolic complications will also be lower when you're restricting your patients to those within 90 minutes?
So that's the interesting thing we'll be talking about on Thursday, is that in the two subgroups who we treat with, who benefited from factor VIIa, the safety is no difference between placebo and factor VIIa. Now you say, why is that? Well, it could be chance, but think about it. If you have this big exploding amount of blood in your brain, you're more likely to put stress on your heart and have an MI. You're more likely to maybe have ischemic events in your brain. So it may make sense actually that the safety is better because we're preventing this growth of the hemorrhage.
That's very exciting.
It is.
Yeah. And the spot sign is not hard to detect either, right?
It's
pretty
well,
reliable.
I would say we're all going to need to be more educated about it, because even as we've gone into the second trial, we're trying to teach people every day, because sometimes it's obvious. You say, oh yeah, there it is. But sometimes it's not so clear. And so that's part of our job, is going to be training people what a spot sign is, characterizing the spot signs. We know that the amount of spot signs you have, the size, relates to the growth. And even the timing of when you see the spot sign actually determines how well you can predict growth. So we're going to learn a lot more about spot signs. That's my prediction in terms of not just with FASTest, but in other studies as well.
Great. Well, this is very exciting, and we obviously look forward to the results of the second trial.
Thank you so much.
Thank you.